Good evening. My name is James Greenblatt, and I'll be speaking with you tonight about something I feel very, very strongly about, integrative medicine for mental health treatment. I will be, talking for probably about an hour, and then hopefully have time for questions. And tonight is really an introduction. I'll be sharing bits and pieces of this very important topic, but I also want to make sure that you are aware of the conference that Great Plains is putting on in Santa Fe in September, where you'll be getting 3 days of information about integrative medicine for mental health. I'll be speaking for about 6 hours on different topics, and it's a very exciting conference. Last year in Sedona was really one of the most exciting conferences that I participated in, because I was with clinicians, physicians, and prescribers who were really interested in exploring this field. As a way of introduction, most of you are aware of the polypharmacy highway, which is the hallmark of, which is the hallmark of our mental health system, which is medications. Medications not only drive what the insurance companies are looking for, what psychiatrists are trained, but also what patients are looking for. In our managed care environment, medicines are not just used to treat an illness. Medicine is used to treat symptoms, and we're going to talk more about that. The work that I try to help physicians and colleagues understand is this concept of the mind is what the brain does, the biochemistry. I like the term orthomolecular because it reflects the words of Linus Pauling and Abraham Hoffer, looking for the right molecule and stressing the uniqueness of everybody's symptoms. And the most important, one of the many important things that I can share with you, understanding an integrative approach to mental illness really helps us with a model not only of treatment, but prevention. It begins to look at etiology, begins to look at why somebody is having symptoms, be it psychosis or depression. Our medical model for mental health treatment is not related to any concept of etiology. It's symptom-based medicine, and we'll talk about that in a minute. I apologize, the slides keep slipping. But anyways, depression is kind of the illness that I'm going to use as a model for tonight when we talk about integrative medicine. And depression is not only debilitating to patients and families, it is incredible loss of work. It is the second leading cause of disability worldwide. And there are estimates in the next 20 years, it'll be the #1 cause of disability in the world. Depression was never used for disability benefits in the United States 20 years ago. Now mental health disability accounts for a large number of those on our disability services. The problem, our patients, our pharmaceutical industries are looking for that pill to solve it. And as most of you know, depression is not a deficiency of Prozac, even though that is part of our culture and part of what we are, our physicians are certainly geared towards understanding. So if depression is not a Prozac deficiency, what is it? Well, the pharmaceutical companies have clearly capitalized on the information that the antidepressants has not been as helpful as we've wanted, because we are bombarded by consumer ads looking at these antipsychotic medications. You see Seroquel and Abilify capitalizing on the fact that the antidepressants don't work. So the advertisements that our children and our adults are seeing are, well, try an antipsychotic, and that might help your depression. This is both frightening in that patients are asking for these medications, and more importantly, or more significantly, our physicians. There's studies the FDA did that over 25 of physician prescribing practices have changed based on these, what we call direct consumer advertising. And what are they capitalizing? The information that slowly have been coming out over the past 4 years that antidepressants do not work as well as we had thought them to have worked. So here, from the medical literature suggesting 94% of antidepressant trials have positive benefits. But what happened is the pharmaceutical companies hid the research. The negative trials were never submitted to the FDA for publication. And so the reality is about half the antidepressant trials failed to show a benefit that exceeded that of placebo. And that is both frightening to our patients as well as our prescribers. So the literature is really clear that for mild to moderate depression, 35 to 45% of patients improve with a placebo. And the slide here is a little joke on if we put M&Ms and call them, double mood enhancing medications, then almost half of our depressed patients would improve. Now, in the reality, in the real world of treating seriously depressed illness, I think that many patients could benefit from medications, and part of what the integrative approach does is to identify underlying causes as well as identifying those people that might benefit from medicines. But here's the reality. Almost half of patients treated for depression respond to placebo. An interesting tidbit is that pharmaceutical companies are doing less research for antidepressant medications because the placebo response has grown so much. It's very hard to get a medication or to find a medication that's going to work better than a placebo for the treatment of depression. So the number of medications in the pipeline, is the expression, for the treatment of depression has gone down dramatically over the past 20 years as pharmaceutical companies, whose goal is to generate a profit, realize that they could invest a lot of money. The medication is not going to work better than placebo, so they're putting their finances in other classes of medications, like the antipsychotic medications. I think it's a powerful reflection of our culture, meaning looking for that magic pill. It's only a guess, but an educated guess. And this is the sad reality of my profession, where we only use educated guesses. There's no objective tool to predict which medications are helpful. So a number of books have come out on the past few years helping people understand that medications haven't been as helpful. Again, I apologize for the slides. But this is a real problem for me, and I hope that people don't jump on the anti-psychiatry bandwagon, because patients have walked into my office and said, certainly about Bob Whitaker, who wrote this excellent book, but came in a couple weeks ago and someone said, could you ask him to stop writing these books because they're very frightening, and as parents and as patients we don't know what to do. And the reality is complaining about psychiatry without offering solutions is really not the answer. And what needs to get out there is how powerful integrative medicine can be for the treatment of mental illness. And it is a solution. It is looking at the individual. And just briefly, why we've gotten into such a problem. Many people have seen this slide before. I use it all the time. But the DSM, our Diagnostic Manual, which is just a list of symptoms. When it started in 1952, there was 107 diagnoses, and it continues to increase. A list of names. And this concept of names are just based on symptoms. So if there's a symptom complex, then we can develop a medication to treat the symptoms. Again, no concept of what is going on, etiology, as well as any objective measurements. So we have objective measurements in the rest of medicine. We have blood tests and urine tests and x-rays. So our patients have the opportunity, the physician can look at a blood test, look at an x-ray, and report to the patient, this is what's causing your cough or your leg pain. In psychiatry, we're just monitoring symptoms. So again, the work of our integrative medicine, which Dr. Shaw has done an incredible amount of work with autism, looking at biological treatments, and my work in depression, looking at biological treatments for the underlying causes of depression. It's a book we published a couple years ago, and the zebra approach. And the reason why I used zebra is that every zebra has a unique stripe pattern. I remember learning this as a child, and it turns out to be true. And we can't treat autism, depression, schizophrenia without appreciating this fact of biochemical individuality. So the zebra approach just begins to help clinicians and patients begin to understand the kinds of things that might be contributing to depression. And we're going to go through some of these tonight, and certainly in much more detail at the Santa Fe conference. Take care of yourself looks at things like sleep, diet, stress, hormones. Exclude, we'll talk about food allergies, celiac disease, and the rest of the zebra approaches you can see on the screen. When we talk about integrative therapies for mental health, we look at some of these nutritional deficiencies, and these are not all of them clearly, but 10 patients walking into the office with the same symptom complex of depression. I can take a month worth of patients and tell you some would be related to a B12 deficiency. Some might have low thyroid, vitamin D. There's an incredible amount of research coming out on mood disorders and actually psychotic disorders, copper, celiac disease, low cholesterol, etc., etc. Integrative therapies are individualized based on our unique biochemistry. So the simplest model that I have is, one, making sure that our colleagues and our patients understand when we talk about nutrition, we're not talking about alternative medicine. We're talking about just good health care and good medicine. And this model, this is based on Sidney Baker in one of his original books on detoxification and healing. It's the model where we're looking at a patient, doing a thorough exam, and the name is meaningless. The symptom complex is meaningless. But what we're trying to ascertain is just two basic concepts. Is there some deficiency state? Is there something that a patient might be deficient in? And you'll see that, the vitamins, minerals, even psychological kinds of influences. And then is there something that patient needs to avoid? Is there a toxic element? And there is an allergy? Is there an autoimmune problem? Is there a metabolite from a Clostridia bacteria in the gut? Very simple concepts that need to be integrated into our mental health treatment. And there are patients that we're going to see that are going to be deficient in one or two nutrients, as well as perhaps toxic with a heavy metal and or a food they're allergic to. When we talk about genetics and we talk about mental health, it is really important to understand the incredible importance of both genetics and the concept of epigenetics. I spend, when we do an assessment on new patients, we have a social worker getting a history, and the family history is an incredibly important part of that. All the major mental illnesses, I have found clear associations, as well as the research, with other family members. It might not be a direct relative, first-degree relative, but we look for aunts, uncles, and cousins to begin to understand the genetic liability. The concept of epigenetics, I'm sure many of you are familiar with, is that it's not just the genes, because it takes hundreds of years for our genes to change, but the expression of those genes. And nutritional deficiencies, stress, are clearly epigenetic influences that affect the expression of genes for mental illness. In all the research, even though there's a very strong genetic liability to depression, what we have found is that environmental factors are much more likely as a risk factor than the genetic factors. So I want to start today just a little bit about neurotransmitters. Every psychiatric medication that we know about today is based on the fact of its effect on one or many neurotransmitters. We know that the major neurotransmitters people are talking about, serotonin, dopamine, norepinephrine, and epinephrine, are really a small minority of the hundreds and hundreds of chemicals that act as neurotransmitters in the brain. Since all the psychotropic medications affect neurotransmitters, it's important to understand that most of these neurotransmitters are under precursor control. And these precursors, meaning the amino acids, are obtained in whole or part from our diet. So what may be contributing to these neurotransmitter deficiencies that our psychopharm world is based on? And we really don't know if there's deficiencies in neurotransmitters, but we certainly notice that there's imbalances or this dysfunction in these systems. And these 5 areas here that I outline would each take an hour presentation, so we're just going to talk a little bit about it, but certainly we talked about the genetic liability to neurotransmitter deficiencies. We're able to look at the serotonin receptor in the brain, and we understand that the genetic differences between the density of these serotonin receptors clearly affect the liability to depression and mood disorders. Diet, we're going to talk about. Stress clearly affects the neurotransmitters. Neurotoxins are a large topic that you'll hear more about in the Santa Fe presentation, and inflammation I'm going to talk a little bit about later. But let's talk about diet. To make the neurotransmitters, serotonin, you see the ST, the dopamine, norepinephrine, and epinephrine, it takes the amino acids, L-tryptophan and tyrosine, and then all the nutrient cofactors you see at the bottom of the screen. This slide's a little misleading where you just see the B6 and vitamin C. There's certainly many, many others. So one of the simple concepts of integrative medicine, that is a major part of the work that I do, is looking at supplementing patients with these amino acid precursors. Let's see if I can. These precursors, tryptophan and tyrosine, can be used as nutritional supplements that can be used with medications, or they can be used instead of medications. When you think about there's an old term called Prozac poop out, where someone responded to an antidepressant and then after a month or 3 months they just failed to respond. Oftentimes we found it's related to just not having adequate amounts of serotonin because of a poor diet or lack of the amino acid precursors. So we utilize 5-HTP and tyrosine as precursor molecules in the treatment of depression. The most important part of the work that we do and why it is really critical, that you understand this concept of biochemical individuality, because I'm going to keep using the analogy of the 10 patients coming into the office for depression. Based on a physical exam or based on a history, I'm not going to know what might be the cause of that person's depression. Some of the symptoms like iron deficiency, anemia, there might be some physical signs of a pale conjunctiva on the eyes or pale skin. But the difference between someone with low B12, low amino acids, low thyroid, oftentimes we're not going to see the difference. I've seen many patients who have low levels of amino acids, and you can see on this test the essential amino acids are all extremely low. And I have this slide of the brown rice and salmon because it's not uncommon, certainly in my practice, where I'm seeing patients that are eating the perfect diet. They're buying their wild Alaskan salmon being flown in, and they're eating their perfect vegetables. And they come in with tests like you see in front of you. And without testing, we can't really tell by a dietary history. So let's just look a little bit about why someone eating the perfect diet, if you will, would have low levels of amino acids. And what I will share with you is these low levels of amino acids are a significant risk factor for depression. Well, first of all, there are many vegetarians or vegans that aren't getting adequate protein. That would contribute to low levels of amino acids. And then lacking the hydrochloric acid and the digestive enzymes to make and break down the acid, and our obsession with antacids clearly interfere with antacid use. So let me just kind of go back. We have a patient presenting with depression. How can you find out what is going on? Again, individual testing, looking at what might be contributing to that. For this 33-year-old female, and I have many patients like this, lack of amino acids. This particular patient, it was insufficient hydrochloric acid, and she was treated with HCl supplements as well as amino acid powder. Not a protein powder, just the isolated amino acids to minimize any difficulty with absorption. And here's a book by Jonathan Wright talking about how important hydrochloric acid is for digestion. Doesn't talk as much about mental health, but we have found lack of adequate digestion critical to understanding many mental health problems. Could it be B12? I believe this is one of the most misunderstood and neglected nutrients that we look at. It's a very, very simple blood test looking for levels of B12. I like to talk about B12 because it really reflects the concept of biochemical individuality. If you look at all the symptoms on the slide in front of you, I can share with you stories of the past few years of patients walking in the office who were found to have B12 deficiency that could have 1, 2, or more of the above symptoms. So we have patients that have presented with a paranoid depression, irritability, apathy, dementia, clear hallucinations, as well as physical complaints, all due to B12 deficiency. It is most common in my practice, and I've looked at thousands and thousands of patients, that the B12 being associated with fatigue, which is certainly the most common in the literature, but what we've seen is associated with panic attacks, anxiety, OCD, depression, and the paranoia. The part that we'll learn more about is what is the appropriate levels, and the norms in many labs are looking at B12 levels over 200 and considering anything over 200 normal. In my experience, we treat everybody under 500, and oftentimes we need to look at a compound called methylmalonic acid. We can pick up in the organic acid test for Great Plains, or a blood test. And methylmalonic acid, if it's elevated, is a major marker for B12 deficiency. Again, we're going to just go through a brief overview, and many of these nutrients we can talk about in more detail at another time. Folic acid is also a very important nutrient in the treatment of depression, and understanding that. Folic acid is actually a synthetic chemical that's made in a lab. Natural folates are found in food. To make the compound L-methylfolate, which is what's absorbed into the brain, crossing the blood-brain barrier, there's a 4-step chemical transformation. And this is really important. And I just want to share a little bit about what we know about folate in depression. First of all, for years, we've been a clear association between low folate and depression. We've known this for about 30 years. We've also found that low folate's been associated with a poor response to antidepressants, meaning if you have low folate levels, you're treated with an antidepressant, those with the lower folate levels had the poorer response. There was a dramatic study done at Harvard Medical School looking at low folate and relapse rates. And again, those patients with the lower folate had a much more higher relapse rate. And then there are studies that looked at folate supplementation to enhance the effect of the antidepressants. The literature on low folate and depression is so dramatic that the drug companies have gotten involved. And if you see here, the drug Deplin is just a form of L-methylfolate that you can get at the in a health food store or online. New Beginnings has L-methylfolate, and here the pharmaceutical, if you can see the ingredients, many of our patients can't really tolerate the chemicals, and it's always amazed me how many chemicals or how many colors it takes to get a little blue pill. But this is L-methylfolate at 15 milligrams per dose. In my experience, you often do not need that kind of dose for the treatment of depression, either as an augmentation agent for using it with antidepressants or by itself. Just want to share with you this study done, published in the Journal of Clinical Psychiatry at Harvard Medical School. The relapse rate for low folate levels, 42% versus 3.2%. Pretty dramatic difference. So a simple blood test, and folate is something that I believe should be supplemented for every patient who has a poor response to an antidepressant or being treated for depression. There's some literature out there that is hinting towards perhaps some negative effects to the synthetic folic acid, both some increased incidence of cancer, asthma, and cognitive decline. I think it's a little controversial, that research, but my preference is to use L-methylfolate in the treatment of depression. I'm going to go through the next slides quickly in the interest of time, but just to let you know that there again is these genetic polymorphisms in the treatment of depression, and there's a certain genetic polymorphism for how we metabolize folate, this TT genotype, where someone has twice the risk of getting depressed. And again, I want to stress that an integrative medical approach to mental health begins to help us look at the concept of prevention. Here's one study of elderly where the higher total intakes of B6, B12, and folate were associated with a decreased likelihood of depression followed for up to 12 years. Again, every additional 10 milligrams of B6, 10 micrograms of B12 were 2% lower odds of depression symptoms. Pretty dramatic. I'm going to skip this slide and just share with you one of the markers we use to look at folate and B12 levels is the homocysteine. And this was a study published in the American Journal of Psychiatry outlining the homocysteine hypothesis of depression. It's a simple blood test that I do on every patient that walks in the office. And if you see here, as folate goes down, and we can also put B12 or B6 here, homocysteine levels rise. So as homocysteine levels increase, the SAMe decreases, and SAMe is critical for the methylation of all the neurotransmitters. And if SAMe goes down, mood is decreased. It's harder to make the neurotransmitters. You see number B here, where folate supplementation, B12 or B6, homocysteine decrease as SAMe is elevated, methylation is improved, and there's an enhanced clinical response. This is really important concept because, again, homocysteine is a very simple blood test, and it also points to the importance of utilizing SAMe in the treatment of depression. SAMe is a very important supplement that we use. This was the study done again at Mass General, Harvard Medical School, and here SAMe was added to the SSRI. And these are patients who didn't respond initially to the SSRI, but when 800 to 1600 milligrams of SAMe was added, there was an improved response to the SAMe supplementation. The one caution we have for SAMe is that bipolar illness is a risk factor where I would not use SAMe because mania is a possible side effect. So we talked a little bit about amino acids, B12, folate, and SAMe as nutrients that are important for the treatment of depression, and these are simple tests that can be done. The other thing I just want to share with you is the importance of dietary fat. We are all familiar with our obsession with sugar-free, fat-free, low-fat, non-fat, light, and how much that has helped our obesity epidemic, which clearly it has not, but I believe has profound implications for the increase in mental illness, particularly depression and mood disorders. Many of you are aware that the brain is certainly 60% of the dry weight is fat, and the essential fatty acids are involved in every aspect of neurotransmission. And as you will learn more about in the seminar coming up in Santa Fe, cholesterol is also a critical part of this membrane that stabilizes the receptors. So adequate dietary fat is critical. And there's so much confusion as to what to take and the ratio, and that we are trying to help our patients understand the adequate amounts. And the two important points that I stress with my patients, one is that fish oil and understanding omega-3 fatty acids are not a quick fix. It can take, we say, up to 3 months to change your oil. This one study showed that it takes 10 weeks for the cerebral membranes to recover after chronic deficiency. So patients might go to the health food store and buy a bottle of fish oil and not feel any better and say that this is not helping. And again, we always come back to testing. I cannot predict if someone's deficient in fatty acids. Sometimes we'll see evidence of skin disorders, dry skin, dandruff, these chicken bumps, but oftentimes there's no physical sign. This is a 36-year-old patient who, if you can see, is chronically deficient, not only in the omega-3 fatty acids, but here you can also see in the omega-6s. And this is not uncommon. And the frightening thing is oftentimes we'll see patients that have not eaten fat or have not eaten fish, but many times, again, these are patients that have eaten the, quote, the perfect diet, but their ability to digest and absorb these nutrients are impaired, either to a lack of appropriate bile acids, lack of hydrochloric acid, and or other risk factors for fat absorption. The next study I just want to share with you is not related to depression, but I believe one of the most important studies that I've seen ever published in mental health literature, published in the Archives of General Psychiatry, the most academic psych journal that we have in the year 2010. And it looked at 81 adolescents and young adults with what's called subthreshold psychosis. So these are patients that had a psychotic episode, had what we call magical thinking, were Asperger's, individuals that were in many circles would be treated with antipsychotic medication. The Australia actually was planning to pass law recommending that all these children with these early onset psychosis that recovered to be treated with antipsychotic medications to prevent further psychosis. Anyways, this group was given 1.2 grams of omega-3 fatty acids, a very small amount in the treatment of mood disorders or psychotic disorders based on the literature, and they were giving this for 12 weeks. And if you see here, after 40 weeks, 5% of those in the omega-3 group developed psychosis and 28% in the placebo group. Dramatic. 5%, only 2 individuals versus 28%, 11 individuals. This is with a simple, safe, inexpensive dietary intervention that prevented the onset of psychosis. Think about the public health implications. Think about if every patient had access to this nutritional kind of supplement, it would make a huge difference in our mental health care. The issues we always come up with is both cost, and for those that can't afford the pills, but more importantly is the information not being digested and or disseminated to our mental health professionals. I don't know how many mental health professionals saw this reference. It certainly didn't get on the cover of Time magazine, published in Wall Street Journal, or the important lay press, and the information certainly did not get in the mental health press. So the omega-3 fatty acids are critical, as well as you'll find out in the conference. Cholesterol is critical for mental health, and we can both test and treat those conditions. Testing is critical. The E, when we go back to the zebra approach, looks at this concept of the right food may be the wrong food. For those of us in this field of integrative medicine, food allergies and reactions to nutrients are an important part of the work that we do, but our colleagues oftentimes have a very, very hard time accepting it. Many things will be discussed during the conference. I just want to briefly talk about celiac disease and why is celiac so important. One, as a nutrient, as a deficiency illness, patients can absorb all the nutrients that we're talking about that are critical for mental health. And as you saw in the next slide, with the impaired absorption of major nutrients, depression has been found in a number of studies, and any clinical trial is to be at least 2 times more likely in patients with celiac. So patients with celiac were found to be 2 times more likely to suffer from depression. The other areas of exclude that are critical would be food allergies. And then one of the most important parts of my practice is looking at the Neuropeptide Test, at this point only offered by a Great Plains laboratory. Here's the test. It's a urine test, and it is critical in our understanding for my practice in anxiety disorders, OCD, binge eating disorder, as well as autism and schizophrenia. As you can see, and many of you are aware of, casein is the protein in dairy. It is broken down to casomorphine. Without adequate enzymes in the digestive tract, casomorphine is not broken down and is as a morphine analog crosses the blood-brain barrier. Gluten is a major protein in wheat. Again, if not broken down completely, gliadorphine, another morphine analog, will cross the blood-brain barrier. And when you think about morphine in the brain, morphine analogs in the brain, we begin to have a tremendous symptom complex. And I can share with you patients profound OCD completely eliminated by addressing the elevated casomorphin with the missing enzyme, DPP4, as well as eliminating dairy. I can share with you patients with anxiety, psychosis, ADHD, all benefiting from understanding if casomorphin and gliadorphin is in the urine. So I use the term in my depression book, psychiatry being consumed as a symptom-based field, and hopefully the work that we'll be talking about at the conference is helping to take this stigma of the measureless medicine away, and for you to understand that there are many objective tools that we can use looking for risk factors for both the treatment and the preventing of mental health disorders. Back to our zebra approach, I'm just going through many of these quickly, but exercise. Clearly, exercise has been shown to be incredibly helpful in the treatment of depression, but how many of our patients can get out of bed and go to the gym? The patients that I'm seeing being coming in for depression are clearly not able to follow what's recommended in the research, that exercise is probably the best antidepressant that we have. What's more common is I was going to get up early to go running, but my toes voted against me 10-1. The psychiatric literature is clear that depression is helpful, although in our clinical world, many of our patients are not able to, due to the depression, get up, exercise, and do what they need to. What this integrative approach is so helpful for is looking at nutritional deficiencies, looking at environmental factors that could be contributing to depression, and oftentimes we're able to help patients get the energy they need to start doing the kinds of health lifestyle changes that we incorporate into the treatment of depression. Most of the work that I do in this book on depression was the concept of what I call, nourishing the brain, focusing on nutrient deficiencies that are critical for brain function. And we've talked about many of them, folate, B12 in particular. But the last part of the book is nurturing the mind. And this is better understanding the mind-body approaches that we do know that can be helpful and beyond the chemistry. And frequently, I get very excited when I see a patient with a deficiency or a toxic metabolite, and without understanding the mind and many of the other mind-body or stresses in life, we're frequently not going to get the effects that we're looking for. So the last section of the book is nurturing the mind, and critical for the integrative approach to treating mood disorders. I'm going to skip the next few slides quickly, but just so, based on that spirituality is critical, and we have shown that studies that people that have faith clearly suffer less from mood disorders and depression. I'm going to focus the end of tonight's webinar on this concept of depression and inflammation, the brain on fire. And I think it's really important, and I apologize, I'm going to skip some of these slides quickly to help us understand the concept, but depression is clearly associated with all chronic illnesses, and now we know that depression and mood disorders is associated with depression. What is inflammation? Well, we know about it when we get sick. We get sick with the flu, and our body responds with many of these chemicals that we call sickness behavior, and these are produced by cytokines in the body. And if you've had the flu, you know what it's like to be tired with no appetite, no interest in pleasurable things. These are all depression-like symptoms, and these aren't caused by stress and psychological stress. These are caused by our body's immunological response to the microbes. And what we've been able to show in the literature for the past 15 years now, patients with depression have elevated immune response, the elevated cytokines. And patients with depression have more of these inflammatory cytokines, less of the anti-inflammatory cytokines. And what's interesting is many of our treatments for depression, sertraline, Zoloft, actually decrease inflammation in the brain. ECT decreases inflammation. We talked about exercise, decrease in inflammation. And the model is really simple. We have a enzyme, IDO, that's produced by these cytokines that break down tryptophan and serotonin. Remember we talked about tryptophan, 5-HTP is a precursor to serotonin, critical for the treatment of depression. Well, this inflammatory response, and this inflammatory response could be the result of many things that we'll talk about, degrades tryptophan and serotonin and sets up a model for depression. And here, you can see what happens. We have these pro-inflammatory cytokines. We make this enzyme, and we have lower tryptophan and lower serotonin. With lower serotonin, we don't make melatonin, so we have sleep disturbances. And part of what happens is we produce more quinolinic acid. And quinolinic acid is something that we test for in the organic acid test. It is a neurotoxin. It increases glutamate, which destroys neurons in the brain. So this inflammatory process in the brain could produce by a number of things that we look at, whether it's stress, whether it's the standard American diet, toxins, infections. We could talk about Lyme, strep, and many others, and allergies. Sleep deprivation increases inflammation, our lifestyle, and obviously chronic dysbiosis. So many sources of inflammation. And the important point that I'm sharing with you is inflammation as a physiological process that's activated in a similar manner by a number of environmental factors. But all of these are depressogenic. So a diverse range of depressogenic environmental factors. Sleep deprivation, inflammation, here we are, environmental toxins, infections, all result in chronic inflammation that contribute to depression. Depression and inflammation is a major area of research throughout the country. And here's just a little amazing fact to me that a new drug, it's called CAT-104, to treat inflammation in diabetes. And what are the ingredients? It's simply omega-3 fatty acids and salicylates. They've raised almost $40 million in 2010. Inflammation is a very important part, and the work that we do in looking for the cause of the inflammation is a major treatment modality when we're trying to understand how to treat depression. So perhaps we can look at a new model that we've had a poor response to antidepressant medications over the past 40 years. The medications that we use, all the SSRIs, affect serotonergic or neuroadrenergic transmission. We have yet to identify mechanisms of how it works, and inflammation is a model that can explain much of the pathology we see in depression. So when we talk about integrative medicine for mental health or integrative psychiatry, again, to summarize, we focus on unique individual metabolism. We look at an individual's testing. We can't say SAMI is appropriate for everybody or B12 is appropriate for everyone or inflammation is the underlying cause. But if we start looking at our biomedical testing, we can begin to understand that. We look at the whole patient. We look at interconnections between the brain and the mind, and clearly trying to increase nutrient reserves to promote long-term health, not the chronic relapsing symptomatic treatment that is our model in the treatment of mental illness. These are just two examples that I use often to help people understand the power of simple nutritional interventions. Quickly, on the right you'll see it's a study in the British Journal of Psychiatry, just adding an essential fatty acid supplement and a multivitamin. This was a study done in England. Patients, these were prisoners in England. Just with these two supplements, 35% reduction in disciplinary offenses and 37% decrease in violence. Huge difference. Again, think of the public health implications. Given an essential fatty acid supplement and a multivitamin that was over the counter, had such a huge impact in the mental health of these patients. It's hard not to bring up, when we talk about nutrition and mental health, the historical implications of B3 deficiency, pellagra. This was a major source of mental illness in the early 1900s. The symptoms of B3 deficiency mimicked the symptoms of schizophrenia. Almost a half of the psychiatric hospitals in the South in the early 1900s were filled with patients that had B3 deficiency. It is an incredible historical story, but more importantly, a simple nutritional deficiency contributed to such a major psychiatric illness. This is not taught in any medical school. It's not taught in any psychiatric residency program, and people ignore the power of how a nutritional deficiency can affect brain function. I urge everyone to read Dr. Hoffer's books on B3 deficiency and schizophrenia and mental illness, and it is a very important part of our both schizophrenia treatment as well as our treatment for patients with eating disorders. Integrative medicine. I like this quote from the chancellor at Duke University. Integrative approach, it flips our current system of healthcare on its head, put patients at the center. It is care that is preventative, predictive, and personalized. And to me, those are very powerful words because it is not, again, part of our mental health treatment. Preventative, predictive, and personalized. And that's what we hope to educate our clinicians as well as our patients. So the terms that I use is mental illness is a reflection of multiple errors in physiology. If we find the cause, we can find the cure. if we find the cause, we can find the cure. I gave a webinar to a group of individuals from a supplement company, and the attorneys for the company did not want me to use the word cure in talking about mental illness because they were worried about the liability. And I can share with you, practicing medicine for over 20 years, that we can use the word cure and we can use the word remission, because if we are looking for the underlying cause, be it a metabolite of Clostridia, HPHPA, that can have profound effects on brain function, be it low cholesterol, low B12, elevations in heavy metals. If we treat the underlying cause, then we absolutely can treat the underlying mental illness. And I use the term multiple errors in physiology because some patients are going to have both a toxic element as well as multiple nutritional deficiencies. And my concept of comprehensive medicine, using all of our tools in our toolbox. I have not thrown away my prescription pad. I still use medicines when needed, but the goal clearly is looking at underlying nutritional and metabolic defects. It's hard not to talk about this epidemic we're seeing in diagnosing our young children with a mental illness, bipolar disorder being diagnosed in 3- and 4-year-old children. I believe this is incredible tragedy, and the tragedy is not necessarily the diagnosis, which I think is kind of misleading and somewhat absurd. The tragedy is the psychotropic medications that are being prescribed to these children. This is a case in Boston in 2007 where a child diagnosed hyperactive age 2, bipolar at 3, and died from an overdose of multiple psychotropic medications, including Depakote, clonidine, stimulants, and antipsychotic medications in a 4-year-old child. It is tragic. There are many, many kids that need medicine, but if you have patients under 6 or 7 years of age, not to do the metabolic testing, not to look at food allergies, not to look at toxic metabolites, not to look at casomorphine, really is just a simple tragedy, because these patients can be treated. As the illness progresses, it gets much more difficult to make some of these simple dietary interventions that we can do in children under 6. And again, part of my mission and goal is to be able to treat these children when they're young, because we begin to prevent these chronic mental illnesses. This has been a really nice study to summarize the work that I'm trying to stress. This was published recently in Neurology in the past year. Sorry for the slide. So here we looked at nutrient biomarkers, and here they examined the relationship between nutritional status, and they did brain imaging in dementia-free elderly. And there were 104 individuals. They looked at levels of nutrients as well as MRI, published again this year. And what they were able to find, distinct nutrient biomarker patterns detected in plasma, interpretable and account for a significant degree of variance in both the cognitive function and brain volume. And here I use the quote, how do we know if we don't look? So what they were able to show in this recent Neurology article is that levels of nutrients detected in the blood accounted for the variance in cognitive decline and the MRI studies in brain volume. Now, the work we've been doing for 20 plus years, the work that Great Plains has been offering for many years has been demonstrating this over and over again. But now we have published literature, hopefully, that our colleagues will be able to understand. And again, how do we know if we don't look? If we don't do the blood test, the urine test, the hair test, how do we know which nutrient deficiencies are related or contributing to the underlying mental health symptoms? So I'm going to stop there. I apologize for going through many, many concepts so quickly. Again, we wanted to just provide an introduction stressing the importance of a biomedical testing model that we will go into more details at the conference in Santa Fe. So I urge you to just look at the agenda so you'll see what will be discussed.